First of all, let me thank Dr. Ghanshyam and his team for organizing this CME. Well, we have heard from speaker after speaker, from Dr. Malviya, from Dr. Ashok Kumar and now Sandeep, that we have improved in our treatment for rheumatoid arthritis over the years. Some of us who have been working in this area for over 30 years will probably identify that how difficult it was to treat any patient who came through the door with suffering with severe pain in the hands and the feet. Well, we have seen many progresses, and I have chosen particularly this slide. This is a new dawn of a new era. This is the sunrise. So what you will see in the next few years, many small molecules will be coming which will be useful in rheumatology, in dermatology, in gastroenterology, in hematology, and so on and so forth. So please remember that it is one of the most exciting discoveries for the treatment for many, many autoimmune conditions. Well, this is the broad outline. I hope that I'm within the time. So, as I said, that over the years the treatment has changed. We had many conventional synthetic DMARDs, then followed by the biologics. And I still remember when we had this biologics and how patient improved. But then we also had some hiccups in the sense that many patients developed inadequate response or the late response, non-responders. Some of them, they developed antibodies to the drug. And then there was a problem with the maintaining of cold chain, particularly in our resource less area. Carrying this to remote areas, if the patient is coming from a very, very small town, then the treatment may not be available so easily. So we had these targeted therapies, and so far there are 3 targeted therapies which has been licensed in the US, and in India we have 2 of them available, tofacitinib and baricitinib. Upadacitinib has been recently, like in November, I think May in 2019, it was FDA approved. So before we go to the targeted therapies, I thought it would be important to just go through a little bit of molecular biology. So cytokine is something which you will be hearing from me in the next few minutes. So the cytokine was the term, and the designation was from Stanley Cohen, and he won a Nobel Prize in 1986. These are the number of substances such as interferon, interleukins, growth factors, which are secreted by cells of the immune system and have effect on other cells. It is like endocrine. Cytokines, after binding to the cell surface, it initiate a cascade of signaling events, which are the key modulator of inflammation. And that is what it happens, and it goes through all kind of inflammation, pro-inflammatory as well as other inflammatory diseases. It plays a very important pathophysiological role in autoinflammatory as well as the pro-inflammatory disorders and in the neurological disorders. Well, Dr. Sandeep was talking about war and everything. I thought probably it would be nice to talk about a similarity, but it will be an orchestra. In rheumatoid arthritis, we have got many, many cells which interacts, signals to each other, and then produces lots of different types of cytokines. So we have dendritic cells, B cells, plasma cell, T helper regulator cells, and macrophage, mast cells, and so on. So what it does, that you have now a confusing slide wherein there are so many interleukins, TNF alpha blockers, different types of interferons, which then give signal to each other, and then it propagates the activity or inflammation, which is why then we get all sorts of problem all throughout the body. So let's sort of go through what happens in the biologics. Biologics, they just target only the single cytokine. Say for example TNF alpha blockers, which Dr. Sandeep was talking about. So it will just target one particular TNF receptor or antibody formation, and then it will neutralize. tocilizumab we heard from Dr. Sandeep about the IL-6 inhibition. Oops. But before we again talk about another important aspect, it is important to understand about the genome. Genome is a sequence wherein within the cell of a human we have more than 2 billion copies within the single nucleus, and out of that there are 500 odd kinosomes which are actively sort of secreting kinases. Kinases, they derive the term from kinin, which is from the Greek word, it is to transfer or to move. So what it does, that it phosphorylates, and the process is called phosphorylation. So from ATP, it will getting activated, and we'll see in the next 1 or 2 slides that how it is this mechanism of action. So then out of that kinases which we talked about 500 odd, we have 4 important kinases for our use, and they are called Janus kinase. Janus is a Roman god. We have 2 faces, one face looks in the front and one looks at the back. If you have been to Vatican, you will be able to see this. And then we have 4 subtypes, JAK1, JAK2, 3 and TIC. All of them have got important mechanism through which it will interfere. So majority of the drugs which are marketed, for example tofacitinib, it acts on JAK1 and JAK3, and then you have baricitinib which acts on JAK1, and upadacitinib, it acts on JAK1, and there are lots of other which will be there in the market soon. So it is very important now to talk about JAKs, and then there is another which will be very clear to you with the new cartoons. So it is something called STATs. It is signal transducer and activator of transcription proteins, and then you have receptors. Let's go to the mechanism of action. So you have this cytokine here which will be bound to the receptors. So it gets bound, and then after binding the JAK gets activated. So what happens then, that we talked about kinases, so that will add and act as phosphorylation, and this will further get activated, and then it will attract the STAT. Okay. So now this particular molecule JAK-STAT pathway, it will get now active. So what it will do, that it will send, it is extracellular, this is the intracellular, and this is the nucleus, and then it will get transmitted the signal to the nucleus. So this nucleus then will have transcriptions, and that will then produce all kind of different types of cytokines. So these cytokines in the JAK pathway, it is so important to understand that, and how the molecules like JAK inhibitors they act, that these will act on the JAKs and it will inhibit, and therefore it will going to completely shut down this pathway for whatever time this drug is floating in the body. So you can see there is a reduced gene product and cytokine production if we actively sort of block this pathway. So once we actively block this pathway, there are so many interleukins, or different types of cytokines which get blocked, and maybe for a very short duration of time. Well, at this stage, I would like to distinguish these 2 molecules, biologics versus small molecule. So the biologics, you have both are, this is biologics are protein, and this is organic small molecule. The structures are very well defined but variable in 3-dimensional structure. These are also well defined structure. The molecular weight for the biologics are very high as compared to the small molecules, which is why it's denoted as small molecules. The stability, which is why we have to give it as an parenteral injectable form, and it is mostly stable administration, as we said, and in vivo half-life is long for biologics, maybe for 7 days, 2 weeks, 1 month and so on. And here it is short. The target, as we have seen in our cartoon, the biologics act as an extracellular mechanism, and this is intracellular. Mechanism action is blocking, and here is the enzyme inhibition, and the specificity is high, but here we have seen that probably even though it prevents JAK1 or JAK3 selectivity, but still it is very variable in a higher concentration. The The manufacturing cost in the biologics is very high, but it is low in here, so that in the future we will be able to see very cheap products available to us as well. The degradation of this molecule is through the catabolism, here it is metabolism, and the generics which are available in India are in the form of biosimilar, and it is the identical product. So, as I have spoken, that the advantage of JAK inhibitors are, it is a small molecule, it will just partly inhibit the cytokine pathway, and it is a shorter half life. So, just imagine a situation wherein the patient is going for an operation or the patient has got sepsis. So, you can just switch off this mechanism for a few days, and then you can again start using drugs after this problem has taken, is over, the problem is over. So, again, there is no, we know that many times after having a very successful treatment with biologics, this treatment does not start again giving a good response as it was doing before. The reason was anti-drug antibodies, but here in this situation you do not produce any antibodies. Well, as we said that because the inflammatory pathways are involved in many autoinflammatory diseases, so already we have license in rheumatoid arthritis, we have license in ulcerative colitis, it is going to be licensed very soon for alopecia areata, vitiligo or atopic dermatitis, and many conditions, we will see that this drug is being used. Maybe it is going to have some role in SLEs as well. Well, the ones which are available so far are tofacitinib, then baricitinib, upadacitinib, which is marketed in US as Rinvoq, and fligocitinib, which has been already sort of given, the things are under file, and probably it may take another 1 or 2 months for the FDA to approve. Well, once we know that this drug works, but what it does in the real life situation. So, we have heard from the speakers that you have an anchor drug called methotrexate, we have combination of various synthetic DMARDs, which are conventional synthetic DMARDs like sulfasalazine, hydroxychloroquine, leflunomide and so on, and then you have biologics, and then you have targeted therapy. So, what you will have to show in next few sort of slides that perhaps it is going to be working in all scenarios. So, in the methotrexate naive patient, patients who are methotrexate inadequate responders, those patients who had combination of conventional synthetic DMARDs, also who had failed various biologics, not only the TNF blockers, maybe IL-6 inhibitor, maybe rituximab and so on. And for each 1 or 2 slides, I will keep on giving you my personal experiences as well. Well, there has been a very long course, this
Dr. Indrajit, we are short of time. I request you to finish in time.
Okay, yeah. So, I think probably we'll have to skip through a lot of slides now, because I think probably we are hardly through the half. Anyway, so let me speak extempore now, because there is no point. Well, what happens that if you use it as a methotrexate naive patient, I had a patient who was a Bollywood celebrity, she showed me that, well, her diary was full with so many engagements she had. Almost every day she was sort of going and toing and froing from various cities and abroad. So, what I could have done, the question to your previous answer to this previous question, then I said, look, at least you can try this molecule, which is which you can take it, and then she responded very well. Similarly, the patient we had who had is just sort of Dr. Professor Rohini Handa's patient, who himself is a doctor, this patient way in Patna. So, he has been suffering with the conventional synthetic DMARDs, and then we use as a first line therapy after with combination of methotrexate, and he responded so well. His impression was that, look, I had felt so good in the next 3 days of initiating therapy. There are many things to talk about, but I think probably for the paucity of time, we will just say that these drugs are incredibly important, very useful tool. You have to go through the same checks and balances before you start the patient as you do in biologics therapy. That means you have to go through the chest X-ray, you go through the hepatitis marker, you go through Mantoux test or the gold quantiferon test. If you are in doubt, do a CT scan. You ensure the patient is vaccinated. We don't have herpes zoster vaccine available in India, but you can do that. Well, there has been a risk of DVT and PE in subset of patients, and especially those patients who happen to have ulcerative colitis, because we have got a license for ulcerative colitis for both tofacitinib definitely. So at the end, I would like to express that I'm glad that I have sort of gone through this segment in rheumatology, wherein I joined as a young rheumatologist, where there was hardly many interventions. We used to see the patient suffering, and then we have now easily achieved a good low disease activity. We can think about total remission. We have now incredibly powerful oral tools, which are available, which is going to be available in many different names in the future with various specificity and sensitivity, and it is going to again make a lot world happier for our patient. Thank you.
Respected chairpersons and dear friends, at the outset I congratulate Dr. Ghanshyam for the excellent Rheumatology Update 2020, and I thank for inviting me for discussing systemic lupus erythematosus, when to suspect. Lupus often looks benign. It overtly looks there is nothing much to do, but when it turns out, it gets into your lab. There are a lot of things to learn about this. The basic issue, if you look at the lupus, if you are not in time to make a diagnosis, the patient may land up with renal dysfunction. If you look at the lupus with vasculitis involving the central nervous system, if you are not in time to intervene, the patient may land up with hemiparesis, or left alone over a period of time may take the life away. So there are several systemic diseases in lupus which can cause organ damage or threatening to the life. So it's a multi-system chronic autoimmune disorder characterized by production of plethora of autoantibodies causing cytotoxic damage and other immune complex formation. And the classical pattern is remission and relapsing. The prevalence is influenced by the age, gender, race. It's more common among the females in 14 to 45 years of age, their reproductive age group. And female preponderance of the disease is 9:1. Family association is very common. And severity is more common among the male as compared to the females. So there is interaction between the susceptible genes and environment which leads on to abnormal immune response. Thereby, if you put this in simple way pathophysiology, there is defect in apoptosis which leads to exposure of the nuclear material, leading to autoantibody formation and immune complex formation, thereby causing chronic inflammation and release of various cytokines, chemokines or chemotoxins, leading to target organ damage. So let's take a case. A 35-year-old lady who was seen for the first visit 1 month ago and reported some oral ulcers on and off, arthralgia, fatigue. Her blood counts, CBC, hemoglobin 11, platelet 1,35,000, LFT normal, creatinine 1.4, but her ANA is 1:80 speckled pattern. Patient came to you in crying. She had called from a lab that she is positive for lupus test. Her cousin had a lupus with renal involvement requiring dialysis, later on dying at the age of 42. So she has already explored the internet. There she had seen this picture. Now what do you do? Do you tell the patient you have a connective tissue disease? I'm just not sure which one. Do you repeat the ANA? It is most likely a false positive. Or do you ignore the ANA? It is common to have positive ANA in patients with family history, and it does not predict the disease. Or you perform thorough history and examination, looking specifically for evidence of classification criteria of the lupus, and some more additional tests so that the results are available when she visits you next time. So everybody agrees that after the end of the talk, you will be satisfied with this D pattern, that as Dr. Malviya said, that history and clinical examination is the most important part of any disease in rheumatology. Classification criteria, there are several classification criteria for for lupus, and mind it, classification criteria should not be confused with the diagnostic criteria. Because of the different specificity and sensitivity of these criteria, they should not be taken for diagnosis purpose. And moreover, these classification criteria is for various studies as an inclusion criteria for having the uniformity of the various studies. So in 1997, classification criteria for the lupus has been developed, and according to these criteria, 4 out of 11 were taken for classifying lupus, and the main drawback of these criteria were that they were heavily biased for cutaneous lupus, and they are very poorly defined for CNS manifestation, and there was not any mention of the complement. Even histopathological proven lupus nephritis is not mentioned in these criteria. So in 2012, Systemic Lupus International Collaboration Clinic developed a new criteria to address the limitation of the previous ACR 1997 criteria. 17 criteria were identified, and again 4 criteria out of 17 are kept for classifying these patients, and out of these 1 clinical criteria and 1 immunological criteria. Or the patient is having lupus nephritis as the sole clinical criteria in the presence of ANA or anti-dsDNA antibodies. So these criteria are cumulative and need not to be present concurrently. However, again, because of the better specificity of these criteria as compared to the previous 1997 criteria, these criteria again failed to diagnose lupus in the early stage. So in 2019, EULAR ACR classification criteria for SLE developed. In this, the most important thing what they did is they took the entry criteria in the form of anti-nuclear antibodies. So if absent, do not classify SLE. If present, then apply the various additive criteria. And these additive criteria was 7 clinical criteria and 3 were immunological criteria, and they have been given different scores. Within each domain, only the highest weight criteria is counted towards the total score. So the patients who are fulfilling the criteria, entry criteria, ANA positivity 1:80 with HEP2 method. Again, they have mentioned that it should be with HEP2 method. And if the score is more than 10, then only they fulfill the criteria for classifying lupus. So this is the various sensitivity and specificity of these criteria. Diagnosis, constitutional symptoms, most of the patient present with fever, malaise, joint pain, myalgia, fatigue, headache, weight loss, anemia, temporary loss of cognitive function. Because they are so often found in other diseases, these signs and symptoms are not part of classification criteria. However, in the recent 2000 19 Euler criteria, fever has been included as a constitutional, and they have given the score of 2. Various specific cutaneous lesions in lupus are malar rash, discoid rash. I will discuss all those. So this is a classical photosensitivity butterfly rash, fixed erythematous rays from the surface, and it tends to appear in nasolabial folds. And then the patient can have discoid rash. These are more disfiguring. Atrophic scarring may occur, and they are more commonly present over the face and the scalp. The patient can have photosensitivity rash, and these may indicate even the flare of the internal organs. The patient can have subacute cutaneous lupus in the form of classic, they are having psoriatiform lesions, scaly lesions, central clearing, and papillosquamous variants are present in these. Livedo reticularis again with antiphospholipid association of the lupus. Then most of the lupus patients, they are having non-scarring alopecia, and most of these patients, alopecia improve with the treatment. And the most important area to look in lupus is ear. So at times the patient may not having anywhere cutaneous lesion, but there may be follicular plugging inside the ear. Then patient can have small vessel vasculitis in the form of leukocytoclastic vasculitis, Raynaud's, or antiphospholipid syndrome. Look for oral ulcers. These are usually painless and patient ignore at times. Then this is the therapy. We can give the patient steroids, hydroxychloroquine, methotrexate, MMF, and so on. 90% of the patient, they can have arthralgias and arthritis. So most of the time in lupus, the arthritis is non-erosive, non-deforming, so-called Jacob's arthritis. And at times they have erosive, if there is erosive arthritis, then there may be overlap of rheumatoid in these patients, so-called lupus. So this is classically how Jacob's arthritis look like. These are correctable deformities. Patient may have ulnar deviation or swan neck deformity or buttonhole deformities, but these are correctable. They are more, again, associated with antiphospholipid antibodies, and they are not typical of lupus. They can present even in acute traumatic fever, paraneoplastic manifestations, Sjogren's syndrome, and recently it has also been found with various PPD crystals arthropathy. Then these are the other musculoskeletal manifestations which can be present. Patient can have osteoporosis because of the steroid use. Patient can have osteonecrosis, avascular necrosis. Again, if there is a single joint involvement, myositis, proximal myopathy can be associated because of the steroids. Even hydroxychloroquine can cause, but most of the time in these patients, the CPK level is normal. 30% of the patient can have fibromyalgia, and these are complex pain, chronic complex pain features which can be present like multiple tender point. Then eye involvement, keratoconjunctivitis sicca, lupus patient can have as a secondary Sjogren features, photophobia, then monoocular blindness, cotton wool spots, and various drugs can cause, like most of the steroids, they can cause glaucoma. As mentioned previously, SUKs can cause bullseye maculopathy, but it's not so common. Then pleural lung involvement, patient can have pleuritis with or without pleural effusion, acute lupus pneumonitis, interstitial lung disease, pulmonary hypertension, alveolar hemorrhage, and then shrinking lung syndrome. And last but not the least, various infection in our setup, particularly in the form of tuberculosis, pneumonitis. Cardiac involvement can be in the form of pericarditis. 25% of the patient of lupus at any time of the disease can have pericarditis, and then they can have myocarditis, limb and sag endocarditis, which is classically red, tan colored vegetations present over the valves on the closure lines, and again they are present in 15 to 50% of the patients, and more common in those patients, those who are having antiphospholipid antibody syndrome. Then patient can have cardiac failure, cardiac arrhythmias, valvular heart disease, coronary artery disease, and females, those who are carrying anti-Rho antibodies, the chances of developing neonatal lupus is more, and they at times do present with congenital variable degree of congenital heart block. Pericarditis is a classical features that present with pain on deep inspiration, and it improves on leaning forward, and patient can have pericardial rub, and ECG may show classical ST elevation along with PR depression. So this is how Libman sac endocarditis look like. Then hematological manifestation can be in the form of autoimmune hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, and of course ESR is usually raised in patient with lupus, and CRP is usually normal. And in case if the CRP is low or ESR is raised, the chances of lupus flare is more. On the contrary, if ESR is raised, if CRP is raised, the chances are the patient is suffering from infection, serositis or synovitis. Then antiphospholipid antibody syndrome, 40% of the patient can have antiphospholipid antibodies. They can present with vascular thrombosis, recurrent abortions, lipidoreticularis, thrombocytopenia, and then catastrophic antiphospholipid antibody syndrome. It is tough to decide at times whether we are dealing with the catastrophic antiphospholipid antibody syndrome or sepsis or lupus flare, because we do lose quite a good number of patients because of delay in diagnosis. Even in the best of treating centers, where the investigation facilities are complete, there also the catastrophic antiphospholipid syndrome mortality is somewhere about 30 to 40%. So it's mainly because of the delay in diagnosis. And delay in diagnosis is mainly because we don't think this has a possibility in patients who are presenting with these clinical features. Then CNS involvement, patient can have delirium, psychosis in the form of delusion, illusions, any type of seizures. Patient can have generalized partial seizures or focal seizures, dementia, aseptic meningitis, movement disorders, cerebrovascular accident. CNS vasculitis is rare, but it can occur in 7% of the patients, and they do present with headache, confusion, rapid progression to psychosis, seizures, and coma. And most of these patients, they have low complement and high titers of dsDNA. MRI may show lesions in the gray and white matter, which is typical of, there is sparing of periventricular area. This is how we differentiate this from multiple sclerosis. And again, CSF is important in these patients, may show lymphocytic pleocytosis, high protein, oligoclonal bands, and at times it's difficult to differentiate whether the patient is having tubercular meningitis or meningitis due to the lupus. Renal involvement, 35 to 40% have renal involvement at presentation, 60% develop renal disease in initial 10 years, 10% lupus patient go to dialysis or transplant. Hallmark of the clinical finding is proteinuria. Nephritis remains the most frequent cause of disease-related death in these patients. So it's important to